from the American Academy of Pediatrics.
The use of genetically modified organisms in farming comes with some pluses and minuses.
A new report from the AAP urges a nuanced approach to feeding our families.
But we also want to advocate, as pediatricians, for long-term improvements in the healthy supply of foods in our country.
But first, it's February, and that means it's time for a research roundup.
So what happens in this study? Well, it would say, is there a new genotypic variant? The answer is no, there is not.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well. Let's start today's episode with a look at the latest articles from the journal Pediatrics.
Joanna, are you excited for February?
I am. January can feel so long and cold, but February brings with it some celebration.
Yes, so many special things. There's Black History Month, Valentine's Day, Mardi Gras, and this year it even gets an extra day.
You're right, and it's certainly long on practice-changing articles in the journal Pediatrics this month, too. I was blown away by the topics for today's First Up segment.
Then let's leap right into the February issue with our favorite editor-in-chief, Dr. Lewis First.
Lewis, welcome back.
Well, Joanna, welcome as well, and welcome baby Zelda to the Pediatrics On Call family. Congratulations.
Yes, I should have held her for the recording because she's in like cute newborn phase now.
Well, my understanding is Zelda was born on New Year's Eve.
That's right.
Is that right?
That's right.
You know, it makes me ask the question, do you know why babies born on holidays are more likely to be little girls?
No, why?
Because there's no mail delivery on holidays.
Touché.
I just thought I would, greet her with an opening volley here for the February. You were talking holidays, and I had to go there. You know what? For as many holidays, there certainly are many articles in the February issue of Pediatrics. So what's on your mind? Which ones do you want to talk about?
All right, Lewis, hospitalist to hospitalist. And for some reason, quality improvement seems to have found a home in hospital medicine. So we have a new target when it comes to my favorite topic, reducing antibiotic overuse. What do we know about helping providers adopt shorter antibiotic treatment courses for community-acquired pneumonia and skin and soft tissue infections?
Great question. And you're right. When we talk about antibiotic stewardship, we're often saying don't use antibiotics. But if we have to use them, another way to be a good steward is use them for just the recommended amount of time and don't overuse. That's why Dr. Louis Vernacchio from Boston Children's Hospital and Harvard Medical School and colleagues got together to put out an article called Improving Short Course Treatment for Pediatric Infections. And as you said, David, for community-acquired pneumonia and uncomplicated skin and soft tissue infections. So to set the stage, Dr. Vernacchio and colleagues recognized that we now have from the AAP's Committee on Infectious Diseases strong recommendations to treat community-acquired pneumonia for 5 days, not 10 days, not 14 days, and uncomplicated skin and soft tissue infections for 5 to 7 days. And they've made these recommendations and said, okay, pediatricians, those who take care of kids, clinicians, let's go for that shorter duration. Well, that's easier said than done. And so to try and increase the number of clinicians who are treating for the right amount of time and not over-treating, they've done a site-randomized quality improvement trial involving the Pediatric Physicians Organization at Boston Children's, or what they call the PPOC, which is not small. It's about 75, 76 pediatric practices, 5,000 clinicians, 400,000 children scattered all over Massachusetts, and they divided all these practices into 4 randomized groups to do a quality improvement trial. They said, all right, group 1, we're going to have an infectious disease person send you an email, and then this is a 3-month trial. On months 1 and 2, after we start out, you'll get a reminder that says how you're doing with writing prescriptions for the right amount of days if you have a child with community-acquired pneumonia or a uncomplicated skin and soft tissue infection. Group 2 got clinical decision support, which is our favorite, the pop-up advisory note that shows up on your electronic health record and says, surprise, you just diagnosed a child with community-acquired pneumonia. You know, the American Academy of Pediatrics says 5 days. Want to think about it? And then you can say yes or no and move on and get rid of that pop-up. The third group got the combo, the educational email, feedback on how you're doing, and the clinical decision support. And the fourth group got, of course, the control award for saying, just do what you do. So 3 months later, what happens? In the control group, when this started, all groups were about 25% of the pediatricians diagnosing pneumonia or skin and soft tissue infections. Basically, it was 1 out of 4. We're doing this for 5 days or 5 to 7 days for the skin infection. However, in the education and feedback group, those clinicians went from double, 22% to 45%. That was good. In the clinical decision support group, 26.6% to 52.3%. These are obviously statistically significant. The combo group went from 26% to almost 70%, 68%. So it was almost 3 times as much. So the question that I know you're going to ask me is, why do I think the combo did better? Well, you're both clinicians and our listeners are clinicians. So let's think about that. First of all, you get a lot of emails. So if at the 1 month and 2 months, somebody sends you email, do you actually read it or did you skip through it? So maybe those in the education group missed the feedback to say, oh, I should really remember that 5 to 7 day rule. How about pop-ups? Come on. When you get those pop-ups to come up, do you just sort of breeze right by and not necessarily see what's there? So maybe that is why when you put them together, if you forgot to read an email, you got a pop-up. And if you ignored the pop-up, you got an email. So you did even better at getting your patients to stay on antibiotics for shorter durations of time. And again, they followed these kids to make sure they were not having complications and all of the other things that come with a shorter duration course. So let's go to the real world. How often do you know that your infectious disease specialists are sending you, Joanna, in the NICU, 1 month reminders about how long you're going to treat, or David as a hospitalist, 1 month reminders as you get a child ready to go home. But really in the outpatient world, these reminders to shorten your duration of antibiotics. Well, it's just not feasible in the real world. And the authors note that and suggest the next piece of improvement would be a hybrid combo. And since we could do an email announcing what the Committee on Infectious Diseases recommends, that's one thing. But maybe that pop-up has a little picture of your favorite infectious disease specialist with a little hello. You know, there's a recommendation to only use 5 days for community-acquired pneumonia. And that may take that combo record over the top without having to do the feedback, the education, and the pop-ups. Let's put an infectious disease quote in the pop-ups and see if that gives you the same effect. Either way, I hope that our listeners set a course. I would say probably a short course to read this study and then think what they can be doing, what all of you who are listening can be doing to be better stewards for a shorter duration of antibiotics for uncomplicated pneumonia or skin and soft tissue infections.
Thanks for that, Lewis. And the personal touch would be really nice, having your ID doc waving at you.
It can be done.
And we can't let you get away this February without also talking about a virus. And so let's talk about RSV, because the new maternal vaccines and newborn monoclonal antibody injections for RSV are a very exciting thing to come along in my NICU world. And as the parent of an infant, I'm especially thankful I got that maternal vaccine for RSV. But is there a risk that RSV will behave like influenza and COVID and we'll have to adjust our vaccines for new variants?
Well, this is a really important question because last time I checked, there was a little bit of RSV that was coursing around, not just the United States, but the world. We've had a surge last year. We're having another surge this year, even in the setting of having a maternal vaccine and a monoclonal antibody that, again, may not be in high supply, but it's available. But these were designed for certain genotypic variants and to make sure we can mount an immune response. And the question is, why are we having this surge? So that's why Dr. Gregory Walker and colleagues at the University of New South Wales put out an article in the February issue called Clinical Genomic and Immunologic Characterization of the RSV Surge in Sydney, Australia in 2022. And basically what Dr. Walker and colleagues did was take a look at about 260 plus RSV infected infants in Sydney, Australia, where they had a severe surge of RSV in 2022. And when they had polymerase chain reaction positive identification of RSV. They did nasal pharyngeal swabs of these babies and then did whole genome sequencing on these babies to say, maybe this RSV is so bad because we have a new variant of RSV that we weren't expecting. And they compared the whole genome sequences in 2022 with clinical severity to see if there was a particular variant that had a type of severity that led to kids needing to be in ICUs. But they also looked at whole genome sequencing from before the pandemic back to 2017 and looked at whole genome sequences from around the world. They also took a look at women of childbearing age and drew antibodies on them before and after the pandemic to say, do they have antibodies that would fight RSV? Or during the pandemic, since we didn't see a lot of RSV, we were all indoors, maybe we don't make antibodies anymore, which would be a problem with the therapies that are out there right now. So what happens in this study? Well, it would say, is there a new genotypic variant? The answer is no. There is not, nor did a particular variant correlate with severity. So the good news, bad news is it's not just a new genotype because they found the same genotypes before in 2017 and around the world. So RSV is out there, but we haven't made a new type of RSV that's harder to wrestle down, as we would say. The second thing is, what about the antibodies? Are you making neutralizing antibodies that can pass to the baby when the baby is born? And lo and behold, from before the pandemic to after the pandemic, these childbearing women were able to make neutralizing antibodies. So they were there. So when you say, okay, if it's not a new genotype and if it's not neutralizing antibodies that were waning, why do we have the surge? To which the authors say at the conclusion of the paper, this is a really good question. It's kind of complex, isn't it? But there's good news. And the good news is that the strategies we have in play right now, the maternal vaccine and the monoclonal antibodies, are being targeted with the right strategy to keep this virus at bay. So while this doesn't tell us what is causing the surge, it tells us what is snot. What is snot causing the surge? Thank you. I'll be here all podcast, or half of it at least. And at the same time, tell us that our strategies of directing our therapy to the common genotypes that are out there and to make antibodies is the right way to go about reducing these surges that have been occurring. But it also says we should keep an eye still on the genotype as we start to put more monoclonal antibodies out there. Let's make sure that we are not mutating our RSV. And so keep doing those whole genome sequences and make sure we're still making antibodies to the RSV that's out there. Good study.
All right, Lewis, I cannot imagine stooping to the level of a pun, but I do want to know, am I doing the right thing with behavior change? Thank you. With motivational interviewing. When I first discovered it, I felt like I'd been handed the Rosetta Stone of behavioral counseling for children and families. And MI seems especially popular for counseling on diet and healthy weight. Do we have to reconsider how effective this technique actually is for all of our patients?
Well, the first thing we need to do is even try it out with a sufficient number of patients to say, does motivational interviewing work to reduce body mass index or BMI? And that's what Dr. Ken Resnickow from the University of Michigan and colleagues did in a study we also have in this month's issue entitled, coincidentally, Motivational Interviewing in Primary Care to Reduce BMI, a randomized controlled trial. And basically for those, I think everybody is aware that motivational interviewing is a patient-centered communication style that focuses on essentially a caregiver or child's intrinsically motivated behaviors of what they actually want to work on, that their values say, I think I'd want to work on that. It doesn't tell you to restrict calories. It doesn't tell you what foods you can and can't eat, but it might tell you to be a little more healthy in your snacking. It may help you to exercise a little bit more or eat healthy portion size. A lot of behavioral strategies we can use if a family feels motivated to try it. The adult studies say motivational interviewing does have a role in reducing BMI, and the clinical practice guidelines published by the AAP in 2023 to take a look at weight management did suggest considering the use of motivational interviewing, but the data was still small studies and it went up and down like weight does, up and down, saying maybe it works, maybe it doesn't. So what these investigators did was they took the American Academy of Pediatrics Pediatric Research and Office Settings Network. They turned to this network of practices around the country, asked if anybody wants to try motivational interviewing in a randomized trial, got 18 pediatric practices to volunteer and divided them. 9 got the intervention, which I'll describe in a moment, and 9 got usual care, which is essentially learning how to code for weight management strategies and a little guide to what are weight management strategies in the clinical practice guidelines. The intervention group, well, first they got up to 4 in-person or telehealth sessions with their primary care clinician to learn about motivational interviewing. Would you be interested? What kinds of things do you want to work on? Then they got up to 6 phone calls or sessions with a registered dietitian to basically say, we're going to help you shape a plan to motivate your child to go with the goal that you want to work on. Then these families in intervention got text message reminders, motivational messages tailored to what they were working on, and parents got lots of educational materials. So the intervention was clinician discussions, dietitian discussions, text reminders, and educational materials. And what they measured was what happened over a period of 2 to 2.5 years in regard to changes in body mass index relative to the 95th percentile for BMI. The children in this study were basically children who were between the ages, I believe, of 3 and 12 years of age. They basically had to be above the 85th percentile, and off we go with the randomization. 2 to 2.5 years later, you would think with all of that intervention on motivational interviewing, did we see a delta, an improvement in body mass index? And the answer is no, we didn't. In fact, if you were in the intervention group, you went up by 0.5 BMI units relative to the control group, which is the equivalent of another kilogram compared to the control group, and you got the motivational interviewing. So does this mean we shouldn't turn to motivational interviewing? Well, hold on for a minute. Because the authors point out there are several things that we should take into consideration with this study. First, when you read the adult literature, they tell you really need 26 plus hours of motivational interviewing to see a difference. That did not happen in this study. Number 2 is there was no way to monitor the fidelity. How do we know that once the clinicians who got training in motivational interviewing in the intervention group had been trained that they actually carried this out over 2 to 2.5 years? Did they hold on to it even though they sent some reminders? Maybe the dietitians by phone were not local in a community to really bond what a medical home should be. So it being further away didn't work. And there's also the issue of why did the people getting motivational interviewing, the kids, gain more weight? And the answer is, well, even though you're not saying I want to restrict your calories, there's still a stigma with participating in a weight management study. And studies suggest that kids who do have a weight stigma will be less compliant, and you see less results in that population. Not to mention that the average BMI in the intervention group was 106% above the 95th percentile. The controls were 103%. And there's other studies that suggest the higher you are away from the 95th percentile, the harder it is to see an improvement. So again, I'm going to ask the question, does that mean we say goodbye to motivational interviewing for children who are overweight and obese? And actually, the answer to that is still a no, not yet. We got a commentary from Drs. Laura Rolk and Michelle White, who are part of the Duke Department of Population Health Sciences and the Center for Childhood Obesity Research. And they came forward with a commentary that said, wait a minute, this is another opportunity for quality improvement. David, you started with that on the first study. In light of the fact, maybe we increase the dose of motivational interviewing. Maybe we get behavioral therapists to do this motivational interviewing and not primary care pediatricians and dietitians who are far away. And then they raised a really important point, really focusing on a family, caregiver, and a child when the world around them has social factors, environmental factors, economic factors that can constrain someone from moving forward with motivational goals. Well, that's part of the solution as well. So they suggest, let's take a look at the environment and the communities these kids are living in. Then let's change some of the parameters, and hopefully we may still see some improvement with motivational interviewing. So my suggestion is that hopefully what I've shared will motivate your listeners, our listeners on this podcast, to basically take a look at this study and commentary, and then perhaps change a little bit of something that was used in this study to try motivational interviewing one more time.
Well, I certainly feel motivated to at least read the articles and all the others in the February issue of Pediatrics. Dr. Lewis first, thank you so much for joining us. And quick question before you go, can February march?
Actually, not only can February march, but what did February 14th say to February 1st?
I don't know.
I heard you're single.
Well, actually, February can't march, but April may.
I like that. April, May. And actually, March may include some incredible articles as well in the March issue of Pediatrics. So if you love February, take heart, so to speak, and let's march forward to the spring where, again, we have some great articles teed up for upcoming issues.
And hopefully we will see you again in May, because I know we have Doctors Kemper and Moon coming up in the next 2 months, but we look forward to having you in the spring.
I may be back. Actually, I will be back and look forward to it. And at that point, Zelda will be driving, won't she?
She will, yeah.
She obviously will be another co-host on the podcast, but 3 months from now.
And she'll be reading the articles just like we all will be. And if you want to see today's articles, just go to aap.org/podcast.
Coming up, we'll look at the benefits and drawbacks of genetically modified organisms in farming. Pediatricians have so much anticipatory guidance they need to offer families in clinic, and it can get especially tricky when parents ask us questions about subjects where evidence is lacking, or we just haven't had the time to study that particular issue.
It's funny. I remember getting an extensive talk about ticks from our pediatrician when we were hiking a lot in 2020. Wonder why. And I think pediatricians are challenged with making their guidance timely and impactful for families.
One topic that always seems to come up in clinic is nutrition. I always try to steer families toward fresh fruits and vegetables, but some of those foods may include genetically modified organisms, and I have to admit, I'm unclear on the science.
It feels like GMOs are now ubiquitous in our food supply, but there is some conflicting information about them. The AAP has released a clinical report, Use of Genetically Modified Organism-Containing Food Products in Children, and we have one of the first authors of that report, Dr. Stephen Abrams, here to discuss.
Dr. Abrams is no stranger to discussing food safety. He joined us on podcast episode 115 to discuss the formula shortage we experienced in 2022, so we're glad to have him back for a discussion on GMOs. He is a professor of pediatrics at the Dell Medical School at the University of Texas at Austin and past chair of the AAP National Committee on Nutrition, and he serves on the Dietary Advisory Committee of the U.S. Department of Agriculture. Dr. Abrams, welcome back.
Thank you. It's good to be back on the show.
So pediatricians don't get a lot of agricultural training in medical school and residency, and you wrote this report on GMOs with the help of 2 listed co-authors and the AAP Committee for Nutrition and Council on Environmental Health and Climate Change. But are there farmers who are part of these groups? How do pediatricians gain expertise in farming practices?
Well, we're not farmers, but many of the people that write this report are experts in food systems, such as the committees that are involved. And certainly when we need expertise, we reach out for it. So one of the co-authors in this group, Dr. Landrigan, has long been involved in these types of issues related to pesticides and farm techniques. Dr. Albin is an expert in things like family food planning, and my expertise has been largely related to nutritional requirements and needs. But we also have behind us 2 strong committees that are experts in all of these topics.
And how did you approach the question of GMO foods that may be different than what other groups have produced on this topic in light of being the AAP?
Our focus is on children. Therefore, our focus is always on the lifetime consequences and uncertainties about lifetime consequences. Many types of studies of toxicities look at acute toxicity, what happens if you take an acute overdose. But we're interested in the long-term consequences for children or for exposure during pregnancy. So therefore, we're looking at data on long-term outcomes and identifying where there were uncertainties. GMO technology, that is the inserting genes into the growth and development of these seeds, is not in itself been shown to be dangerous, and we make no suggestion of that. Our concern is that the use of GMO products has increased considerably the use of specific artificial pesticides such as glyphosate. So the GMOs themselves, we make it clear, are safe in terms of the genetic manipulations that are done.
Now, the use of GMOs is becoming more widespread, and with that, more attention. I have to admit, I'm still unclear on what crops GMOs might be. I envision corns with multiple ears or, 10-pound soybeans. Where are we going to find these GMOs, and what do they do, actually?
So the most important value for the farmer on a lot of this is to be able to increase the yield of crops. So GMOs are permitted only in certain food sources based on FDA guidance, which is very detailed. And the paper lists the specific foods. For many consumers, the most common foods that are GMO are corn and soy.
What about other stuff? Do I need to be worried about strawberries and bananas and apples or not so much?
Relatively little. Apples can be produced GMO. Most of them are not. And most of other fruits and vegetables that we commonly eat are not GMO in the United States.
Steve, you just mentioned that the actual insertion of genes in GMOs isn't a problem or health risk, and the health risk comes from the use of pesticides. So how does planting GMOs change how farmers manage their crops and grow them?
So, unfortunately, the use of GMO technology, which does increase yields, does also increase the use of these pesticides, such as glyphosate. And this increase in use of the pesticides has become a marked increase in recent years.
And what about the glyphosate is bad for kids?
So, there are some data that remain controversial that suggest an increased risk of cancer, and particularly non-Hodgkin's lymphoma. There are other recently emerging data suggesting that may affect the microbiome, and there's a very recent study suggesting some concern about developmental outcomes. There are also animal data supporting each of these types of concerns. These are by far incomplete data sets, and therefore people looking at these data sets have come up with different conclusions about them.
Steve, you're a nutrition expert. It seems like a lot of our concerns have shifted away from this or that macronutrient like fats or carbohydrates, more toward these ultra-processed foods. What is the relationship between ultra-processed foods and GMOs?
Well, in and of itself, they're not necessarily linked together. However, it's certainly true that many ultra-processed foods contain components that include GMOs in them, such as the corn, soy, or some of the other ones. The relationship between ultra-processed foods and health is a very complex one that also is not fully established. There are several recent studies that demonstrate some concern about increase in obesity and other types of disorders, but that also is controversial. Nonetheless, we certainly as pediatricians are looking to try to get people based on their financial capabilities to try to avoid a high level of ultra-processed foods in their diet.
You know, there is a recommendation in the AAP report to try to steer clear of GMOs in kids until the health risks of glyphosate are better understood, with an emphasis on choosing more organic crops. But don't organic crops also use pesticides? And by buying them, does your exposure to these harmful chemicals significantly drop?
Well, it's certainly true that there are organic pesticides that are used in the production legally of organic foods. However, the artificial pesticides, such as glyphosate, are not used in organic production. So one does decrease its exposure. Although some have expressed some concern about some of the organic pesticides used, the ones that we're most concerned about are some of the artificial pesticides would not be found in organic products.
I love this discussion of organic foods. In light of the AAP's equity agenda, do you worry at all that promoting the generally more expensive organic crops might have unintended consequences, causing some families to consume fewer fresh fruits and vegetables just due to the cost?
Absolutely, we've been concerned about this. And that's why it's important that this report is designed for pediatricians to use in counseling families. As pediatricians have to have some contextualization to it with the family. Again, we're trying to decrease the amount of exposure to some of these products, not necessarily completely remove them. And in no case would we expect the family would decrease its purchase of fruits and vegetables because of the need to avoid GMOs, especially if finances are limited. So pediatricians do need to take an equity lens, do need to be aware of the financial circumstances. But we also want to advocate as pediatricians for long-term improvements in the healthy supply of foods in our country. So therefore, we feel it's important to point out unknowns and uncertainties and potential risks while recognizing the financial issues that may affect some families.
So if you were running a general pediatrics office, what would you recommend your staff say to families about GMOs when they're offering anticipatory guidance?
I think most families probably will not bring it up on their own, although some may. I think the most important thing is that for pediatricians to continue to focus on healthy diets, fruits and vegetables, raw fruits and vegetables whenever possible or frozen, limit the amount of highly processed foods, although again, these do not need to be completely excluded, and be aware of the cultural and financial sensitivities of the families. If families specifically ask about GMOs, I think one can recognize that GMO-free products are a little bit more expensive. Organic can be substantially more expensive, and therefore they have to make sure that families understand that, and the families don't feel like they should avoid fruits, vegetables, or other types of products because of the GMO. That's not what we're saying at all.
I love that message. And Stephen, if you are what you eat, then do you have any last takeaways for our listeners about GMOs?
I think that they need just to keep an eye out on the discussion and keep an eye out for how different groups around the country and around the world take a look at the upcoming science. The point of an AAP report and our report in particular was to focus on the need for more research, the need for more human-based information, and the need to kind of be cautious about what we feed our children. This is true of all our food supply. For example, think about the recent episode in which there's contamination of different foods with heavy metals. Again, our food supply is basically safe, but parents have to be aware of risks that exist.
Well, thank you for helping us all be aware. And Dr. Stephen Abrams, thank you so much for joining us today as well.
Glad to be here.
To read the clinical report, Use of Genetically Modified Organism-Containing Food Products in Children, visit our website at aap.org/podcast. At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. What's your Say Ah this week, David?
We just got back from celebrating Christy's birthday. We were in Chicago for an AAP meeting.
Oh, happy birthday, Christy.
Yay. She enjoyed it. We tacked on a few days and really planned almost nothing except a few meals. I had a chance to go out with an old friend from residency we haven't seen in 10 years, and I pointed across the restaurant, and I was like, I know that guy. And my friend and Christy were like, David, you're at a random restaurant in Chicago, and stop pointing because that can't be the guy that you know. And
I do say that to my 4-year-old all the time. Just stop.
I kept an eye on them. And when the table of former pediatric residents from the University of Chicago stood up, I brought Dr. Gary Fernando over to the table to say hi to my friends and prove that I am not crazy.
Well, now you have to send him this episode and make him listen to the end.
I think he's a listener.
My Say is just about being reminded how hard it can be to have a newborn because you're always trying to keep them safe. Not that they're fragile, because we do a lot to babies in the NICU, and I know they're not fragile, but you're more worried about their immune system. And I just want my Say to be a thank you to everyone I've texted in the last week. And it's a privilege being a pediatrician and knowing so many other pediatricians. So my Say is just like to every pediatrician out there, thank you for answering those text messages of your friends. And it's worse when your friend is a neonatologist who maybe knows too much and perseverates on things. But my Say is just like, pediatricians are amazing, and I'm so glad I have so many in my phone. It's a privilege.
Sounds like a say, whoo.
Yeah.
That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at how the infrastructure around us affects our health.
We'll talk to Dr. Michelle White about a new policy statement on the built environment. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.